and also all the colleagues. I'm very happy to be invited here. So I'm going to share my slides. I have skipped so many slides, so let's start. So my talk will be the management of dementia. I will focus more on Alzheimer's disease because it is the most common dementia type you encounter in the clinic. And some of the patients experience even minor stroke, and the other one is a very severe stroke. So this is a very interesting topic and very practical. Sorry. Okay, I'm going to touch about the basic concept of MCI and then put one cases to discuss. So as we all know that dementia is a massive growing public health, the figure show us that it's doubling almost every 20 years. And let's put your attention in Southeast Asia, in the country, our country, that is very fast, even faster than the world statistic. It's almost double every 10 years. So two obstacles in managing Alzheimer's disease is a delayed diagnosis. Most of the patients came to our clinic in the moderate stage with a very severe behavioral problem. And we know that the early recognition, especially in the mild stage, will give us an opportunity to intervene with the drug with a better outcome. And it also gives the family time to arrange their future legal aspect and so on. And early detection can avoid the unneeded investigation, which we always seen in our country. The other thing is the patient who have been diagnosed didn't have the current available cholinesterase inhibitor or memantine, or the one who received this drug have a suboptimal treatment. Clinicians are very, very careful, even too careful. They don't put the patient in the optimal dose. So the basic concept is, I'm going to touch about the basic concept. Cognitive impairment actually is identified as a reduced performance of variety of cognitive domain. Okay, it should be measured in the psychometric testing. So the graphics show us the left one is the elderly, and the young one is the right is a young one, and then you can see that in the normal condition, there's one standard deviation differ between the two groups. And some individual, however, they reduce of the cognition is so fast, is beyond the age-associated memory impairment or cognitive impairment. We can see that in the 10% on the left is the patient with MCI or mild cognitive impairment, and the 5% is a patient with dementia, especially the Alzheimer's disease. So MCI refer to the impairment of one or more cognitive domain which do not substantially impact their activity of daily living. The patient can still go to the hospital, go to the office, make some easy judgment, but sometimes they came up with a very bad judgment. Dementia, on the other hand, is indicates a more severe cognitive decline, which have interfered their ability to do the activity of daily living, and most of them at the middle stage of the disease has some behavioral and psychological symptoms, which we call the PTSD. The graph on the right show us that the empty circle is the normal elderly. You can see the cognitive is so stable, even within the 4 class of age group. And the square one is the MCI. You can see the MCI is declining so fast. in every cluster of these patients. And the triangle is a CDR.5. That means that the patient actually in the very, very mild Alzheimer's disease. You can see also it's declined so fast, almost the same with the field circle one, the mild Alzheimer's disease. So this is a continuum of a normal MCI and Alzheimer's disease dementia. So MCI or dementia is not a diagnosis, it's a symptom. It may be caused a variety of etiology. MCI, the most common is a prodrome of dementia, especially Alzheimer's disease. Of course, now we have MCI, vascular MCI, or MCI in the frontotemporal dementia. But not all MCI will convert to dementia. Those with worried well, with reversible cognitive dysfunction, just a depression, can improve to a normal cognitive status. And one thing I have to draw your attention is medical illness, just like a thyroid dysfunction, especially the hypothyroid and the vitamin B12 deficiency can cause the symptoms just like a dementia MCI. And the last thing is we have to avoid the use of anticholinergic drug, which we usually use in the Parkinson's disease, just like a trihexyphenidyl, or the antidepressant, as amitriptyline, we use a lot for the painkiller, especially for the neuropathic pain. So this is a case of the 73-year-old retiree with chief complaints, 6 years of progressive episodic memory decline. He keep repeating questions, statements, asking the same question in the morning, afternoon, and nighttime. He was disoriented to time and place when she was brought to my clinic. ADA was severely impaired, and the MMSE is a 15. Then he exhibits some fear of death, which we call it the delusion, and also the stubbornness, which we call it the agitation. MRI scan shows us the bilateral temporal atrophy in the hippocampal with an MPA score of 2. So he was diagnosed as a moderate stage Alzheimer's disease. So this is the clinical diagnostic criteria for Alzheimer's disease. On the left is the core symptoms or clinical features of Alzheimer's disease: memory decline, insidious, and also it is not caused by other medical illness. And now we are encouraged to use the MRI to confirm our diagnosis. Of course, in the Western country, they try to use CSF and also PET or PIB scan for labeling for Alzheimer's disease. The hallmark of Alzheimer's disease, amyloid. So what is the management of MCI we can offer? Unfortunately, until now, we don't have pharmacological treatment for MCI, except close monitoring and also informed consent to the patient and family about the progress they are going to face. The clinician is not advised to offer cholinesterase inhibitor because it is not effective. The clinical, the non-pharmacology we can endorse is a regular exercise. I think I have to consult with the previous expert. And also we have to recommend the patient for the cognitive training. Usually cognitive training in the memory training, we have a structural cognitive training with the computer. So about management of dementia, of all the diagnosis, the management of dementia can be divided into two intervention. The left is a psychosocial intervention, teach the family how to cope with the the cognitive problem, how to cope with the behavioral problem, and the right is a pharmacological intervention. We can see here that Alzheimer's disease, vascular and Lewy body of Parkinson's disease dementia can be administered cholinesterase inhibitor, except frontotemporal dementia. It is useless to use a cholinesterase inhibitor. So Alzheimer's disease is a not curable disease. That's why our aim would be targeting on the quality of life improvement through management of cognitive behavior, functional rehab, with the intervention of non-pharma and pharma approach. Of course, also support to the family, a caregiver is very important because family and caregiver can easily burn out or very stressed in caring the patient with dementia. So this medication we use to improve the memory and other cognitive function. Cholinesterase inhibitor, donepezil, rifampicin, and galantamine should be used slow titrating up dose. Memantine or amyloid receptor is indicated for moderate to severe cases of Alzheimer's disease. In the mild Alzheimer's disease, it is useless. So the graph shows us that the response of donepezil is dose-based. That means that 10 milligram perform better than 5 milligram. And the effect is temporary. That means that if you stop the medication, the therapeutic effect declines. So this is one of the study indicate that donepezil can be used more than 2 years. But in the clinical practice, we use more than 5 years. So one common side effect of cholinesterase inhibitor we have to aware is nausea, vomiting, or we call it GI upset. And the other thing is in some cases, donepezil may provoke the bradykinesia or syncope. So should be pay attention for the patient with a sick sinus syndrome or FE block condition. If the patient has some REM-sick behavior because we install the donepezil in the nighttime, we have to move it to the daytime. Amyloid receptor antagonist and memantine has fewer side effects. On the contrary to the cholinesterase inhibitor of side effect diarrhea, this medication memantine cause constipation, and confusion is the most side effect if we install or administer the medication too fast. It should be started at 5 milligram and then titrate up to 20 milligram. If we start it then at 20 milligram, it will get confused. So what is the recent advance of Alzheimer's disease? Now we know the Alzheimer's disease actually the amyloid persists in the brain 15 to 20 years before. So now we have several phases of Alzheimer's disease. We have preclinical, or we call it pre-MCI, and we have a prodrome Alzheimer's disease dementia, we call it MCI, and the Alzheimer's disease itself. So we can see here the S0 is a healthy person with any amyloid. S1 is a patient with amyloid but no neuronal injury in the brain. S3 is the patient with amyloid tau, and they have some cognitive complaint. But the neuropsychological test is normal. It's different from MCI. You should have the impairment in the MCI or in the neuropsychological test. So we have we put it all together with so many stages of Alzheimer's disease. Today we're going to focus on the MCI and AD or dementia. Unfortunately, until now we don't have the disease-modifying agent for Alzheimer's disease. That means that we cannot cure Alzheimer's disease. What about the stroke and dementia? The relationship between the stroke and dementia is very complicated. Multiple mechanisms underlie association between the two. Stroke can cause dementia. We call it a vascular dementia. But sometimes stroke only precipitate the onset of Alzheimer's disease, which we call it a post-stroke dementia Alzheimer's disease. And besides, cardiovascular risk factors just like hypertension, diabetes, dyslipidemia can cause both stroke and Alzheimer's disease. This is a bar graph show the diagram show us that dementia can be caused by stroke and stroke can cause dementia. And the risk factor can cause both dementia and stroke. And you have to pay attention in the middle, the small vessel diseases. There's a white matter hyperintensity, or the microbleed in the brain can cause bleeding in the brain, also ischemic in the brain, cause dementia and cause stroke. So in between, researchers now focus on the small vessel diseases. Well, post-stroke cognitive impairment is very frequent. In the clinic, you can see a lot of patients who, after a very much stroke, but could not return to their work. It is because of the executive function impairment. So up to 64% of the stroke survivor has some degree of cognitive impairment, and 1/3 of them develop post-stroke dementia. Post-stroke dementia, post-stroke cognitive impairment is any impairment in the cognitive domain. Post-stroke dementia is dementia after stroke. Whether it is a pure Alzheimer, a pure vascular, or Alzheimer plus stroke. So this is the latest update of the post-stroke dementia. Post-stroke dementia is a part of the vascular cognitive impairment. It's a big umbrella, any cognitive impairment caused by the vascular event. This is a risk factor, the demographic, the older the patient, the higher risk of getting a post-stroke dementia, and the stroke severity also. How can we prevent the stroke, post-stroke cognitive impairment? The primary prevention should start it early in the early life, especially in the midlife. We have to control rigorously the cardiovascular risk factor. For the secondary prevention, we have to do the optimal stroke care, thrombolysis and acute stroke, treating patient in the stroke unit, prevent the delirium, seizures, rehab, early rehabilitation, and the use of anticoagulant or antiplatelet as indicated. Pharmacological intervention, there are only cholinesterase inhibitor and memantine was approved by the American Heart Association and American Stroke Association. Memantine, even though have a very subtle effect on the cognitive, it improves the behavioral problem in post-stroke cognitive impairment. AGB recently have a meta-analysis stated that AGB or extra ginkgo biloba can improve the cognition, ADL and global rating. Actofergin and cerebrolysin are the two medications which have several clinical trials, but due to the methodological issue, it is not recommended yet for the clinical use. The other ongoing RCT is using the neurites, or what we call NeuroH2, to improve the cognitive impairment, post-stroke cognitive impairment who are not demented. The other is cognitive rehab using the galantamine for the post-stroke cognitive impairment rehabilitation. So this is the study of acetylcholine in 1 year treatment for post-stroke cognitive impairment. You can see that at the end of 12 months trial, there's improvement in attention and temporal orientation, and also the executive function for the acetylcholine use. Non-pharma also raised attention for the researcher. Physical intervention, such as physical training or cumulative exercise, can improve the cognitive impairment. The good thing is physical intervention is widely available and low cost in treatment. The other study is a finger study. It's a multiple domain lifestyle intervention. In this trial, they control the diet. They have a program exercise, cognitive training, and risk factor management. And they have a regular check for the 2 years in the elderly with a high risk of dementia. And they found out that this intervention can decrease the cognitive decline of the patient. Take-home messages is for dementia and MCI. Currently, we don't have any pharmacological intervention to modify the diseases. MCI is not recommended for the use of cholinesterase inhibitor. The only suggestion we can do is ask them to do more exercise, physical exercise, and follow the cognitive training. For the Alzheimer's disease, currently we have the symptomatic improvement medication, cholinesterase inhibitor and memantine. And these medications should be installed in the early stage, titering up, and a long-term monitoring. You can add on cholinesterase inhibitor and memantine in the moderate stage if indicated. For post-stroke cognitive impairment, we have to realize that it's very frequent, and we have to control the risk factor rigorously, especially in the middle life for the prevention. The optimal management of acute stroke followed with the early rehabilitation, it can minimize the stroke severity. The use of antiplatelet and anticoagulant is indicated for stroke prevention. Current pharmacology use cholinesterase inhibitor and memantine, and AGB have some evidence-based data. Physical training and multiple domain lifestyle intervention is advisable to reduce the cognitive impairment. Thank you.